Asthma is a fairly common obstructive lung disease affecting about 5% of the population of the United States. It generally affects people who are younger, or at the very least has its onset at young age, and as it carries forward throughout life, results in a degeneration of the lung parenchyma, worse with smoking. You want to compare asthma to COPD. I'll do that a little bit in this lecture, but in the pulmonary section, you'll learn about asthma and you'll learn about COPD, and you want to be able to compare the two. Let's start off by talking about the pathology of asthma. Asthma is a product of both bronchoconstriction and inflammation. It is an obstructive lung disease, and it is IgE mast cell mediated. When you talk about obstructive lung disease, what you want to do is talk about the spectrum of a human's life. And two big milestones are adulthood and getting old, about 18 and 65. If you're going to diagnose someone with asthma, it's generally going to be before adulthood. Now, someone can have asthma their whole life, but they will be dealing with it their whole life. Chances are you will not diagnose someone with asthma in adulthood. If you do, it's more likely to be COPD, the product of smoking and environment and genes. Now, you could diagnose COPD younger, depending on those environment and those genes, but generally in between, what you're looking at is athletic asthma. To find a patient who has asthma, what you should look for is the telltale signs of bronchoconstriction, and that is wheezing. Now, not all that wheezes is asthma, but if you hear wheezing, you should at least consider obstructive lung disease. Patients who are having an asthma attack or suffering from the symptoms right now are going to have wheezing from bronchoconstriction, as well as shortness of breath and cough. This is someone who's actively having symptoms. But you should look for the kid who has the A syndrome. People who have asthma are IgE mast cell mediated, so may also have atopy, like eczema, and food allergies, and allergies to seasons or to foods. And you'll notice that these are all in response to triggers. They get exposed to an allergen and they set off one of the three A's or multiple. So it's generally going to be a younger kid who has asthma, atopy, and allergies, who then ends up with a diagnosis as an adult. It is possible to find someone who maybe doesn't know they have asthma, or get someone a little bit later, and if you see that person, what you want to look out for are decreased lung sounds and hyperresonance. These are ominous signs that the person's not doing well. That is, there's lots of air trapping and no room to move air. To diagnose asthma, you get pulmonary function tests. And the pulmonary function tests are going to show obstructive lung disease, which means an FEV1 over FVC, which is reduced. Asthma is both reversible and it is inducible. You reverse it with beta agonist, and you can induce it with acetylcholine agonists. If someone comes in thinking they have asthma, what you're going to do is get them pulmonary function tests. And what it's going to show you is that either they're normal or they have obstructive lung disease. If they're normal, you want to try to induce them. Use methylcholine. If the methylcholine challenge causes bronchoconstriction, then indeed they have asthma. If it does not induce, since they did not have abnormal PFTs to begin with, this is not asthma. On the other side, if you find a reduced FEV1 over FVC, you have obstructive lung disease, you want to try to rescue them. You do that with a bronchodilator, albuterol. And if you're able to reverse the symptoms and the findings, that is asthma. They've got the diagnosis. If it does nothing, it's not asthma. And when you have asthma diagnosed, you then need to know how to treat it. And since the problem is both bronchoconstriction and inflammation, it should be no surprise that the treatment is going to revolve around bronchodilators and anti-inflammatories. All right, bronchodilators are going to come in the form of short-acting beta agonists and long-acting beta agonists. Anti-inflammatories can come in the way of inhaled corticosteroids, leukotriene antagonists, and oral steroids. You generally want to avoid oral steroids. Now you can use the stabilizers, nidochromal or chromalin. And you see the omal, chromal suffix, prefix. This is going to be used only in the case of athletic asthma when they know what the triggers are and they're going to be exposed to it anyway. So they say, oh, well, I'm going to go do that thing, and so I'll take this medication before I get exposed. Because it's so unreliable, this is almost never the answer unless it's so clear that to be athletic asthma that it can't be anything else. But when you're treating asthma, you're going to use primarily the bronchodilators and the anti-inflammatories. So what do you start and what order do you do it in? Well, it depends on the severity of the asthma as determined by their symptoms and their FEV1. And we break it down into 5 categories. And it's going to be based on daytime symptoms, nighttime symptoms, and the FEV1. For 1, you're going to see symptoms occurring in the daytime less than 2 times per week. And nocturnal symptoms occur less than 2 times per month. And the FEV1 is about 80%, so mostly normal. As you go down, it's going to become more frequent and more severe. Stage 2 is going to occur less than once per day, but more frequently than less than 2 times per week. And nocturnal symptoms are going to occur less than once a week. This still represents about an 80% FEV1. If the person is having symptoms more than once per day, or having nocturnal symptoms more than once per week, they move up to 3. And this generally represents an FEV1 of 60 to 80%. Class 4, the FEV1 is going to be poor, less than 60%. Nocturnal symptoms are defined as frequent, and the daytime symptoms are still greater than once per day. Now 5 I actually make up. 5 exists, and it's called refractory. That is, even though you've treated someone with all the right stuff, they're still having symptoms, their FEV1 is still low. Refractory asthma requires oral steroids. And the way this is supposed to go, in terms of the nomenclature, is intermittent, then persistent, mild, moderate, severe, and refractory is when everything else doesn't work. So you use this symptom frequency and FEV1 to drive your treatment. And it's going to escalate in a very reliable pattern. You're going to start off with a short-acting beta agonist. They only use their albuterol inhaler when they need to because it happens so infrequently. But if it happens more often than not, then what we need to do now is give some sort of controlling medication. You do that by adding an inhaled corticosteroid. If still more long-term control is required, you add to that a long-acting beta agonist. It's very important to know that you do not use a long-acting beta agonist on its own. If you do, you increase the risk of asthma-related death. The reason is that you are giving them only beta agonists and no anti-inflammatories. If you're going to give someone a long-acting beta agonist, they must be on inhaled corticosteroid. The short-acting beta agonist alone doesn't do it. They must be on inhaled corticosteroid. Leave it at that. If you still have more symptoms, the next thing to do is to increase the dose of the inhaled corticosteroid and continue the LABA. And ultimately, if you fail and you're going to refractory, this is when someone gets put on chronic PO steroids. Now, for all intensive purposes, we left this out of the discussion. A leukotriene antagonist and inhaled corticosteroid are essentially the same thing. Use them interchangeably, but don't use them both. But here's the thing. If someone comes in and needs more medication, chances are it's not the asthma. What you want to do is make sure they're doing the things right. So first, you want to test, do they know how to use their inhaler? And so you observe them do it. The second thing you can do is add a spacer so that the inhaled medication is getting in their lungs and not in their mouth. And finally, you really want to stress this, medication adherence. Because chances are it's the patient's lifestyle or use of the medication, not the need for more medication. So you need to make sure that that's it. Don't put them on more medication. Make sure they're using what they got the right way. All right, so that was asthma, its diagnosis and what it looks like, a lot on how to treat it. Now let's talk about the asthma exacerbation. That is someone who has asthma, it's exposed to a trigger, they come in with coughing and wheezing. So someone comes in with the signs and symptoms of an asthma exacerbation. You're going to do everything. You're going to give them oxygen to keep their pulse ox above 90%. You're going to give them nebulizers, and that is ipratropium and albuterol. You are going to give them steroids, oral or IV, depending on their severity, and you are going to assess their peak expiratory flow rate. That's going to tell you, are they getting better or worse? There's one of three things is going to happen. They're going to get better, and they're going to go home. They're going to get worse, and they're going to go to the ICU. Or they're going to need more time, and they're going to go to the floor. All asthma exacerbations revolve around rapid-acting inhalers or nebulizers and steroids. The way you deliver them and for how long is determined by how bad they are. You can send someone home or treat at home an asthma exacerbation with some oral prednisone and some increased use of their metered-dose inhalers. While some patients are so sick, they're going to need continuous nebulized treatments on a ventilator. The way you assess that is by saying, what is your response to my initial therapy? The people who can go home, have no oxygen requirement, who are not wheezing anymore, and whose peak expiratory flow rate is greater than 70%. This person's getting better. They still need metered-dose inhalers and some prednisone to carry off their asthma exacerbation, but they can do that at home. The person who needs the unit has an increased oxygen demand, a rising CO2 on a blood gas, decreased lung sounds. Now, the absence of wheezing might sound really good to you, right? Like, yeah, they're getting better. But no, if you have decreased lung sounds, the wheezing is going away because they can't move any air. That's a bad sign. Or a peak expiratory flow rate less than 50%. Now, ideally, they'll know what their best is, their peak expiratory flow rate. They'll come to you and say, my peak expiratory flow rate at best is. And you have to compare what they can do relative to what they're able to do when they're healthy. The person who goes to the unit gets a ventilator, IV methylprednisolone, and continuous nebs. The person who goes to the floor is going to still get nebulizers, ipratropium and albuterol, and will transition to MDIs. They get IV steroids, methylprednisolone, and are transitioned to oral prednisone. These are not continuous and will start off scheduled and eventually get spaced out. Now, if the person is doing really poorly and you've done all the right things and they're still not getting better, you do have some options left. And there's not really a way to pick one. This is salvage therapy. If someone's having a CHF exacerbation, you can try racemic epinephrine, sub-Q epi, or magnesium. And there's not really a way to choose between them. You generally do all of them at once. Okay, that's asthma, obstructive lung disease, a lot you gotta know. How to make the diagnosis, how to spot it, the escalation of treatment, and then the asthma exacerbation where you do all the right things right off the bat. Albuterol, ipratropium, steroids, and find out how they respond. If they respond well, they go home. They respond poorly, they go to the unit. If they just need more time and more nebulizers, they go to the floor. That's asthma.